And so a vaccine actually is the best thing because most of the deaths happen in children under 5. Because we already have vaccines for other diseases, a vaccine for malaria would actually give more protection and allow them to gain immunity, and they're protected in the time that they're most vulnerable. So it doesn't help to just know that we have 200 facilities in Nairobi. We need to know where they are so that we're able to understand people who are sufficiently served, those who are underserved, and perhaps where certain services are required.
One, we are up. Hi guys, welcome to another episode of the Geo Habari podcast. I'm your host, Yariwo Kitio, and I'm pretty excited about this new episode. This week's conversation is centered around health. So we're going to look at a lot of insights around healthcare and the intersection of geospatial data, which I think is a very interesting conversation, with a key focus on a pilot project on the malaria vaccine. So a lot of insights around what it really means to have a malaria vaccine within this pilot phase, and most importantly, where data sits within this particular conversation when it comes to healthcare and geospatial data. That's this week's conversation. Please engage with us on social media and also on our Spotify page. But before we get into the episode, I'll have our guest introduce herself. Hi, Angie.
All right. Hi, May. Thank you for having me. My name is Angela Moturi. I am a GIS researcher working with the KEMRI Wellcome Trust research program based here in Nairobi. Most specifically, I work with the Population Health and Impact Surveillance Group. And our focus really is about understanding the trends in health within different groups of the population, understanding equity, and ensuring that our health systems are able to meet the needs of our population at the moment and in the future. And I know a big question I get a lot, even with my own family, is how did I end up in the healthcare sector?
I was going to ask you that.
Yeah, that comes up a lot. So I like to call myself a bit of a late bloomer when it comes to GIS because I did my bachelor's in natural resource management. So by the time I was in third year, I had never even heard of GIS. So when I had the first class, I was immediately intrigued because I'd always been excited about how technology can help to solve our problems faster and more effectively. And so, as soon as I had my first JS class, I was sure this is what I wanted to focus on. So, I've actually done some work in the energy sector, but my recent transition into the healthcare sector, I think, is going to stick because I'm now doing a master's in public health. So, I think you'll see me a lot more in this space than before.
I'm so happy to have you, Angie, and thanks for agreeing to be in this conversation. Wait, you got introduced into GIS in third year.
Yeah, yeah. So for our course, because we were doing more of the natural resources, so really the aim was for us to be end users of GIS, would like in the wildlife sector, in agriculture, and these are really also the areas where the focus. When you get out of school, you're always told like big areas where GIS is being used. First, that comes to mind is agriculture, transport, energy sector. So even the idea that it could be applicable in health was new to me, and this is also something I have seen even within my career at the moment, is that a colleague of mine went for a GIS day. And among the students, that was the thing they were most curious about. It wasn't about the nitty gritty of how you use GIS, it's the fact that you can use GIS in health. So for them, that was very surprising. Yeah, and I think this is an important conversation to have so that more people are aware of the opportunities that exist and so that we can also build because healthcare is a key factor that will play long term in our country, across Africa, and so it's better to us to have more people in the space so that we can even do more with the data we have and the tools that we have within the space.
Thanks, Angie. From where you sit, how do you think these two areas align, right? How does GIS play a key role in healthcare?
Well, I think the biggest part is first to look at health. I think when you think about healthcare, we tend to focus on individual level, like about specific diseases, specific treatments. But when you consider health at a larger scale, I guess, you're looking at the health of very different people, and where you are is a very important factor that will influences your health. So if I can use the example of in Nairobi, you wouldn't be concerned about contracting malaria because it's influenced by the environment. Malaria species are not able to survive within this particular temperature, and so the environment isn't suitable. And so when you're looking at health, for example, as the county government, because health is now a devolved function, malaria is not the biggest thing you're looking at if you're based within Nairobi. However, for someone who's in Busia, someone who's in Kilifi, decision makers in those areas have to look at the specific conditions that are affecting their populations. And so I think that's the best thing that brings GIS and health together is the fact that location and place impact where your health is and the health of different people and groups at a time. And again, GIS helps us to gain insights at a broad level so that you're able to make decisions faster and more effectively. And so you're both able to see the big picture and drill down to small areas where you're like, okay, I know this entire county is doing really well, but you're able to identify places where perhaps a small ward that isn't doing as well in areas like vaccination, ANCs, so all the different services that health encompasses, you're able to look at each different one and look at the factors that affects this from population, environment, their access to facilities. This is the beauty where JS comes in because you're able to bring all those together and make decisions much faster.
Like the malaria vaccine, which I know is one of the projects you'd mentioned in one of our sites, just one of the most exciting projects you are a part of. And I think it would be interesting to just create like a runway into that conversation, maybe for context for our international audiences, on why a malaria vaccine on this side of the globe, particularly because we're now in Kenya. Why malaria specifically?
Yeah, that's a very important thing. I think because we keep hearing about certain diseases, we think that by now we should have gotten a solution. But really, as of 2020, 94% of all the malaria cases and 95% of the deaths were actually happening in Africa. This is because other parts of the world have been able to kick out malaria. And so this is a burden that is very specific to us, but also the solutions lie with us. And the malaria vaccine, among there've been so many different interventions to try and control malaria because there's no silver bullets that we do this and we've sorted malaria across the entire country because there's different factors that influence malaria within different locations. And so there's been long term, particularly in Kenya, which I can speak of, there's been different interventions being in place, such as bed net distribution, indoor residual spraying is done very often. There's different things that are being done at the same time just to ensure that we're able to control malaria. And a vaccine would be the next step. And this is a vaccine that's taken actually a very long time. It was first approved in 2015, but the development took decades before it became available. And so to have it is a key tool to allow us to, I think, take the next step because we've been able to roll out different interventions and they've helped, but still the burden remains high. We need to ensure that we are adding tools that are even more effective and that offer children protection. And so a vaccine actually is the best thing because most of the deaths happen in children under 5. And so because we already have vaccines for other diseases, a vaccine for malaria would actually give more protection and allow them to gain immunity and they're protected in the time that they're most vulnerable before they can gain their own independent immunity. And so with this vaccine, at least this is the first vaccine that's been approved, but recently there's been another one. But the project I'm speaking specifically would be about the RTSS vaccine. And so this one gave about 40% protection, and it was aimed to be given at children between the age of 6 months up to 2 years in 4 doses. So at least that would allow them to gain immunity slowly. But again, this is a new vaccine that's being introduced with a new schedule. So our current immunization schedule typically runs from birth to about the time when you're 18 months and you're receiving your measles second dose. So that window already is mostly within the age of 1. And the malaria vaccine now came in and is over a longer period than other vaccines. So that already presents problems in terms of making sure that children are able to complete all the doses so that they're able to get all the protection. And so a lot of what's the questions that we had first with this pilot is, was the implementation program very effective in ensuring that you're able to reach the children and they're able to gain the protection that they need? And so that's a lot of the questions we were trying to answer. And because not many countries were piloting it, initially only Kenya, Ghana, and Malawi are the countries that are piloting. And that's based on a history and a legacy of implementing malaria interventions effectively. And so we kind of stood out in terms of being able to pilot this in a system that would show that the malaria vaccine can be delivered efficiently across the populations that most need them. So 26 sub-counties in Western Kenya were chosen in order to now evaluate the vaccine first for the first 3 years from 2019 up to 2024, after which the vaccine will now be rolled out to a wider population. And because there has been great success in these first years, we do see the vaccine being rolled out in a larger context. But it was important to first understand what lessons we had from the pilot that will inform how we roll out to a larger group.
This is very new. This feels like I'm about to become a doctor. So, is it accurate to say that vaccines come in after you've probably exhausted all the other options towards reducing that disease burden? Is that accurate?
No, actually. The thing is vaccines, actually they should be the first resort once you've developed them, but the challenge becomes that they take so long to develop. COVID was a very unique instance because now there was a lot of funding, there was a lot of collaboration across the world, which expedited the process. But typically, it takes decades before you are able to get a vaccine first that is can be given to humans, and then that gets tested within populations, and then you need to test if it has any negative effects. So it's a long process, but hopefully, because science is developing, our technology is becoming more advanced, we're able to solve some of these problems much faster. But really, I think if you have vaccines have been the biggest tool actually in combating many diseases. So if you can look back at diseases such as polio, diseases such as tuberculosis, they used to be such a big burden. But because we were able to get vaccines that you can deliver to children early, this become less of a problem for the population over time. Yeah.
Like, at what age are they getting this vaccine?
That is between you getting it in 4 doses. The first at 6 months, another at 7 months, another one at 9 months, and the last one at 2 years, so at 24 months. So by that time, you at least getting the full dose, you're protected. But this is because the largest burden of deaths in malaria are in children under 5. So getting that particular age group before they turn 2, you're actually protecting them early on. It serves to reduce the mortality that's attributed to malaria over the longer term.
Could you talk about maybe some of the gaps that exist within our healthcare systems across the challenges that you faced during maybe the monitoring, the program evaluation, or the data collection?
So, for one, I'd like to state the importance of studies such as ours that look at the delivery of different interventions and look at that across time and across space. Because not only do you get a better understanding of specific health interventions and how they're delivered, but you also get a sense of the overall health system and its performance through now small examples of how we're able to weather shocks or whether the health system struggled in the delivery of different types of health programs. And the example I would love to give is the malaria vaccine and COVID. Because the malaria vaccine was implemented in late 2019, it really was in its infant stages when COVID hit. And so already it's a new intervention. And then we are in this space where a lot of uncertainty is going on globally and locally as to how to deal with the spread of COVID. And this led to different measures that restricted movement. And also there was a lot of fear in the air in terms of places to access, confidence in accessing health facilities. And that has an impact overall in how people will seek care for different conditions. So one of the challenges the health system had in that time specifically was first to be able to deal with the spread of COVID and be able to deliver care to patients, but also ensure that routine services that were being offered did not suffer. And one of the key routine services is vaccination. And because of the quick response and I think the adaptability, we were able to weather that storm quite effectively because across several vaccination and other services, the Kenyan health system and several other countries in Africa were able to sustain delivery of services. And that meant that there wasn't a drop in the number of children receiving vaccinations. So in that case, we were able to keep the program going. And that's a testament of the strength and adaptability of our health system when there's, I think, dedicated focus and an aim to ensure that we are able to keep certain systems going regardless of what's happening to ensure that people receive care and receive services with ease. But we were also able to study the flip side of this, in which case systemic challenges we have kind of experienced more often locally. And by this, I'm specifically going to talk about health worker strikes. So on the back of COVID, there was a health worker strike nationally and also more locally in different areas where health workers downed their tools, protesting the lack of PPEs and health coverage because of the risks they were exposed to in the time of COVID. And we actually saw that had a bigger impact in vaccination services than COVID did. And so that speaks to how different challenges not everything has the same impact as you would expect. So it's important to understand how different challenges actually play out in real time. So what happened is that we saw a big drop in mini vaccines, and so that meant that children did not receive the vaccines at a time that they perhaps were due to receive them. So what I would say is that a child who was due to receive several vaccines in December was not able to access a facility that was offering the vaccines. And several things can happen in the aftermath of that. Once health workers do return, then yes, some children do actually come back to make sure they catch up on any vaccines that were missed. But not all children come back, because now it's also a matter of schedules, caregivers, availability, and also confidence in the health system. It kind of actually suffers in such shock. And so the next alternative is that some children don't come back at all. And that creates missed opportunities and situations where first the child themselves is vulnerable to disease and infection, but also that they can harbor disease and infection within the communities, which puts everyone within their vicinity at risk of diseases such as measles, which we are trying to control.
And it's pretty interesting because when you're talking about like the healthcare strikes and all that, when you're looking at it externally, like it never really hits you how some of these problems affect other programs that are running. And like when you're saying it now is when I'm like, oh wow, that actually affected this program. Because when you're looking at it outside, it's like, what does that strike mean when it comes to community level? And now what you're saying, like that gives us a lot of perspective. Do you mind maybe talking about how data now comes in to addressing some of these gaps, right? How do you monitor it? First, for a start, the role of geospatial data and what data sets were very important for you that you thought this is literally like the masterpiece that made this project a success or made the project sort of be able to monitor even the outputs and the impact at a very granular level.
So to answer that, I think is I'll need to give a bit of background because it's always research is never ending. We kind of build upon the work that we do from previous times, and this helps us to solve and answer questions in the future. And so I think let me start with the biggest piece of information that we needed that we worked on in the period of 2021 to 2022 was in creating a master health facility list that was updated up to the current period, which by then was 2021. And the reason this was a big undertaking and an important one, particularly within the program, was the fact that prior to this, like there's been efforts to do this uh, prior, like in 2003, 2008, and the Ministry of Health themselves actually maintain a website which you can access that shows the different health facilities that are registered within Kenya, as well as some of their services. But when it comes to answering questions such as looking at access to health facilities, whether populations are served, it is important to have this data that is partially linked. We know where health facilities are in space. So it doesn't help to just know that we have 200 facilities in Nairobi. We need to know where they are so that we're able to understand people who are sufficiently served, those who are underserved, and perhaps where certain services are required. And so this was a work we did in collaboration with the Ministry of Health, is just to get their main listings, which is first the Kenya Master Health Facility list, and one that comes from their routine data. Yeah, so this is an important like work for first the Ministry of Health in order to understand what health facilities are operational, what services are available, and this helps also to forecast and plan for the health system as we grow, as the years go by, and as new conditions come up, and as some of them are able to handle. And this is not just an important issue in Kenya, but also globally, because there's also an effort by the World Health Organization to build a global master health facility database. And I think the one example I can use is during COVID. It was important to know which hospitals had ICU beds, how many ICU beds they have, how many oxygen tanks were available, because then you're able to direct patients to the facilities that are able to support their needs and identify areas where you need more capacity, I guess, or perhaps areas that perhaps don't even have a facility and you need to place one. So that's the first big data sets that we needed to have. And I think that one I think we'll discuss a bit further on why that plays a big role in all the work that we do with regards to health. Another one is this question that comes about when you're looking at monitoring evaluation, you need to have the data. And that's a big thing. You need to have the data of vaccines being given. And within the health sector, there is actually a very strong culture of recording data within health facilities. So, health facilities are actually required by the Ministry of Health to report the services they have administered at a monthly level across all the services they give. And so, this gives us data that we can analyze across different locations and also across different time periods so that we can see the progress that's been made. And this is wonderful because you're now able to look at what we have done successfully in the past and look at the impact of our interventions. And this is, I think, a thing that's wonderful about the work that the Ministry of Health has done, but I won't lie, it's not perfect. Even with a system being available, there are still challenges with it in terms of having all the facilities report their data. And there's been a challenge, particularly with getting private health facilities within the fold. And so I think I'll also draw back to the fact that we updated this listing was because prior attempts had focused on the public sector. But going forward, it's a matter of the public and the private sector working together. And so we need to understand what everyone's capacity is, what services are available, and how we can strengthen each other and work together so that we can improve. So I really think those are the main two data points that help. And also the general ones that we use all the time in terms of having really good, clean boundaries that are updated. And I think that's a big thing is having data that is up to date so that you're able to track how things are going at levels that make sense for policymakers. And so right now we can speak to specific sub counties because we know exactly what area they need and based on the populations they have. So I think those are the biggest ones.
And let me take us back slightly, Angie. When you talk about like a master facility list, what attributes are typically within a master facility list? What else is really important within this master facility list as you're building it?
Okay. So for one, we need to know what type of facility it's registered. So we need to understand, is it a clinic? Is it a hospital? Is it a health center? Because that gives you an idea of what level of services to expect within different cadres of the health sector. Another part is to understand who owns and manages particular health facility. So again, there are many players within the health sector and each have their own ways of managing health and resources. So we need to understand how many are being managed by faith-based organizations, how many by the Ministry of Health, because this allows the ministry also to plan for resources to be made available to all these different health facilities and to understand how to get them all the services that they need. Another thing we need to know is the services they provide. But a key thing that makes a master facility at least useful is a unique code for each facility that is registered in a country, in a region. There needs to be a unique code that everyone, no matter which sector, within NGOs, anyone who is working with the health facility should be able to gain a particular code that allows that any data we collect, we can actually link across various databases and across various sources. And so that's first important in order to understand how many unique facilities we have because names tend to match in different places. I know there's a Maili Saba in one country, there's a Maili Saba in another one, but this code also helps us to track facilities across various different sources and be able now to understand.
So it's like a primary key.
Yeah, exactly. So I think that's the first thing that we need to have across health facilities.
Do you mind talking about like existing systems? Like now, for example, DHIS or these systems that they use to report. I'm assuming the data that they report on the service, for example, if it's vaccination, 10 kids came in, and how this eventually links in or syncs with this master facility list to give more insights. What does this look like when you talk about existing systems versus now this master facility list that was built that you guys really worked on as well?
All right. So a big thing first with the master facilities, at least we're able to characterize our health facilities. Where are they? What do they do? Who owns them? That just gives us attributes about what the facility is. But the system you're speaking about, the DHIS2, which stands for District Health Information System, is actually a platform that's web-based. That is not, it's not applicable just to Kenya, but it's a platform that's used across many countries actually in Africa. And it's a system where health facilities are able to store their data. It's an information management system. You're able to link first. I know I have 5,000 health facilities. And so ideally, my DHIS2 system should reflect the same facilities and allow me to track what services they have actually provided across time. So I know there's X facility in Kiambu. I can be able to know in January 2018, they saw this many inpatient students, they saw this many vaccinations. And that allows me to understand the services that are being given across time. But so first, you can be able now to evaluate health facilities at an individual level in terms of how is their performance. Is there a preference for certain facilities? Because one thing you will see from the data and that reflects the situation is that sometimes people avoid government facilities because of there've been persistent issues in terms of staffing, the strikes, supplies being available, and people will opt to go for a higher level facility such as level 6. Some will come to Kenyatta in Nairobi when really they're just coming for vaccination, which is available close to them. So when you have these two systems, they can be linked easily so that you know where the facility is, but you also know what it does. And that also gives you a perspective into what populations are doing and how populations behave. Yeah.
Maybe do you mind taking us through some of the specific project findings from this malaria vaccination project that really relied on geospatial data, right? And like without this, then we would not have otherwise found out. And then how this plays out into interventions.
So I think one of the main findings, and I've alluded to it earlier, is that with the vaccine particularly, we saw that people, or rather parents, would take their children to facilities that are a bit further away, like high level facilities, hospitals, referral hospitals, which were presenting a very large volume of vaccinations. But you find that small health facilities that are within communities tend to do very low numbers. So overall, many children got the vaccine, but where they got it also matters because it means that tells you something. Why is it that uh, caregivers are opting to go much further to get simple services when these should be available at a lower system? And this is important because it kind of bleeds into other services because the point of having a tiered system, which is what we have in Kenya, is that certain facilities, such as clinics, do different services compared to a level 6. And so, what would make it successful is for primary services, such as vaccination, such as ANC visits, these should be catered to by lower level facilities that are accessible within the community. Yes. But when you find that more people are going to level 6, now uh, hospital health workers within level 6 are taking in a large number of patients to do services that could have been catered somewhere else. And then that means they're overloaded to actually carry out perhaps the more complicated procedures. And this is how we end up with referral hospitals, which are overcrowded and overwhelmed, and a system that is very overwhelmed, while we have a primary healthcare system that is actually underwhelmed. So that finding was actually useful because now that guides how policy will go. There's need to do further work to understand why is it that parents choose to avoid certain facilities. What are the systemic issues? Some we know, but there could be other unique things that come up in terms of perhaps there's a perception that they are not able to get the vaccine, particularly at this one, or they prefer the vaccine there. And so these that guides insight into how we should communicate to people about new interventions, what things are important for them to know, and how we can facilitate them being able to access care in the most effective way and the fastest way. Another thing I think that GIS really built up on, and this is a thing that comes up often, is a lot of the time when we look at health, we look at aggregate estimates. So, for example, we hear estimates about how vaccination coverage has performed nationwide, perhaps at the county level, but we don't go, um, I think, a bit more granular in terms of at this ward. So you tend to have very large estimates that actually are
Yeah.
very wide area estimates that hide the little disparities that exist at lower skills. So it might be that perhaps Kilifi County did very well in terms of vaccination. However, you will find that there is a very specific sub county or a very small ward where you find children are perhaps not going to get vaccinated. And with GIS, we're able to drill down to these details. And a key part of that is actually open data sets, such as I'll speak about population data sets like WorldPop, which allow us to actually get estimates of population at a pixel level, sometimes up to 100 by 100 meters. And these, I think, they're models using census data, but now you're able to now understand at what level I expect this number of people, but this number of vaccines were given. So did they give less what when people in this specific area are not coming? And I think having such data sets available is actually quite informative. And this data set, for example, has been available till 2020 and there are efforts to keep it going. But it shows how GIS is actually very key in order to understand the trends at subnational level. Because we've done really well in terms of our health services, perhaps in getting coverage at a wider scale, it now becomes more important to identify small areas that are left behind. And that helps us to target our resources much better. Yeah. So I think I would say those are the biggest ones. Yeah, but yeah, it's also just important because GIS is this useful. You're able to bring these many data sets and get that information much faster. Because ideally, perhaps I would just have vaccine data one in one area, another agency has population data, but now we're able to bring all this knowledge together and be able to now inform each other. And I think that's a very big part of research is just being able to bring and harness knowledge so that we're able to move faster. And GIS is a very great tool at doing this and doing this efficiently. And it gives us many methods. So because we can't afford to keep doing surveys in person because resources are scarce, this actually is one of the greatest tools for countries in low and middle income areas.
I really like that on like the granularization of what GIS really means. And like I'm curious, Angie, if for example in a particular location you've identified maybe okay, this is like a red zone where a lot of people weren't vaccinated within a certain ward within a sub county, what does that mean for the bigger population? What's the impact of that?
Malaria is unique in its way because it's transmitted by a vector. So you can't transmit malaria person to person, but it's transmitted by a vector. But the challenge with malaria specifically would be that there are children who are under vaccinated, means they're less protected. So they're more likely to have severe outcomes. So death might be more likely in these populations because of the lack of protection. But when we're looking at vaccine preventable diseases in general, things like polio, measles, which I think I will highlight especially, these are diseases that, especially for measles, you can transmit from one person to another. So when it comes to children not receiving the full dosage, then that means we retain pockets of infection. And this has actually been seen because there have been outbreaks in Western Kenya, in Northern Kenya, because children are under vaccinated in these areas. And so that means the entire population remains at risk. As long as these children are under vaccinated, they are able to first get the disease and transmit it to others. And so that becomes the biggest thing when you have vaccines, if you have a way to prevent it, especially with those that are very easily transferable, it's important that you ensure everyone is protected.
One of the biggest gaps we've had as, do I say as techies or do I say as myself, is when it comes to communication of results, there's normally gaps in between. In the sense that as a techie, how I communicate would probably be technical jargon as opposed to, using words that actually make sense to my main consumers or to my main stakeholders. And within this project, I think it would be interesting to talk about how do you convey this information to a policymaker or communities or these health facilities.
And I agree that that is a challenge that techies face a lot. And I won't like even researchers specifically face in different areas because we tend to be very close to the side of how this gets done. We want to understand which tool was used. We want to understand what model, how effective the model is. But when it comes to communication, I think this is a whole different skill set. I think this requires a very different skill set. And the primary thing I think I would say is knowing your audience is fundamental. So perhaps if I am, depending on who I'm talking to, there are different things I will communicate. If I am with a more GIS audience, I will go into the nuts and bolts of how we carried out certain analysis using GIS. But when you're looking at a stakeholder who's never seen GIS, the only thing perhaps they can understand is the map. And that's the beautiful thing about GIS is that you're able to communicate a lot with just a map. even though I know it takes a lot to get to that map, which some people may not see, but the map is actually quite effective in how we show places, perhaps the extremes of things, and what that means for different stakeholders. That's a call to action, because now if I perhaps highlight a very specific word, that's an immediate action where they're like, we need to go and look at this word specifically. We need to go and look at this particular hospital. And so really it's sometimes not about explaining the entire process. Just focus on the area that is most important to this person and what their needs are. So I think that's more of a land skill that we all need to kind of get. Especially with GIS, we will be talking to people who are in non-technical fields, and it's important that we communicate in a way that first shows the usefulness of GIS without overwhelming our audiences, but also gives them the information they need quickly. Because in essence, that is the aim of all the analysis we do, is just to make it more efficient and make things go faster. So that would be the one thing I'd say. Knowing your audience is important.
And there's something else you mentioned in our side chat that I think really resonated with me, because it's something we don't really think much of. And it would be like the importance of not just getting data, but having context and looking for ways of understanding what that data really means. I don't know if you can put more words into that.
Yeah, I think that's actually a thing I've seen quite a lot. I think the unique thing is because my background wasn't fully GIS and not techie. The first thing I tend to do myself is actually just understand what problem we're trying to solve. So it's good to have the tool. It's good to know I have a tool that can answer this question, but it's important to refine the question that you're trying to answer. Regardless of whatever industry you are in, energy, for example, now me for health, you need to understand what are the different things that affect the particular area that I am studying. So when it comes to vaccination, first it's understanding which populations are targeted. What are the normal issues that come around vaccination? Do people go for vaccination? Where do they go for vaccination? So having this background will actually help you craft your analysis in a way that's meaningful. Because it's one thing just to show people that, oh, certain facilities were doing better than others, but what does that actually mean? What could be driving that? Because that you might not get from the data, but you understand from context information that you research, that you seek, that you gain from also people you're working with. But and I think that's a big thing that perhaps I can say within the research team, particularly our group, is that our we tend to have a mix of expertise and specializations within the group. So we have one person who's in statistics, another one in GIS programming, another person who's doing in-person interviews and works on the social behavioral side. So this mix of knowledge actually helps to strengthen what you do, because now you're able to understand meaning for different audiences. And I think that's a thing that most techies need to, I think, expand on, is just to understand, yes, we have tools, yes, we have means to make the world better or perhaps improve processes, but why are these processes important? What's the most important pinpoint? Because it's one thing just to create a tool for something, but perhaps the need for the particular population isn't there. And I think that means getting out, talking to people, understanding what how the world works and what issues exist. So that's a thing I think that affects techies across the board. Anyone in IT, any programmers, that's a thing. We tend to be in our bubble building our apps. And we need to understand, does anyone actually need the tools we are giving them? Or how do we figure out what problems need solving?
I really like that example you've given on like the diversity of your team and what that really means. I think that's a very good take home. And I think last but not least, you've definitely said you're pursuing like a master's in public health. What are you excited about or looking forward to? And maybe future engagements you really want to get into within the health niche? What does that look like for you?
Oh, actually, yeah, I think I'm excited first to get more into the health space. Once I made the pivot into healthcare, I was actually really excited about the opportunities that exist and how few people in GIS specifically are in the field. And when I chose to pursue my master's, it was really about bridging the two realms even better, because with an understanding in GIS and a better understanding in health, I think that improves my way of fast dealing with problems and also looking at the solutions that we can have particularly in sub-Saharan Africa. So I don't have very specific routes because my path so far hasn't been a specific one. And I think that's a thing I live by is flexibility. But the one thing that stands is the fact that I want to be able to solve problems for my country. I want to be able to use the tools I have to solve any problems, particularly now within the health sector, and improve this going forward. I think that's the best way I can put it. Yeah.
I love that. Maybe talk about like guys can read the paper because I know there's also a malaria vaccine paper as well.
Yes. So the in the Wellcome Trust research program, we make sure all our data is fast available where possible and doesn't inflict on data privacy, but also that our work and results are easily accessible. So all our work is published in open access channels. So I think I just tell people to Google my name and the population health and impact surveillance group, and I think our work will be very wide. Yeah, because this is work that actually has been going on for a long time. I am just one cog in the wheel, and I would actually be very excited to have more people in the space and discuss. I'm also on Twitter sometimes. Yeah, so that also helps.
Thanks, Angie. So I'll link Angie's social media pages in the description for this particular episode. I'll link her paper as well. Oh, and anything else she gives me, basically, any resources that might be useful for anyone who wants to read more about this vaccination project. But thank you so much, Angie, for being here and agreeing to talk to us about this project. That's the end of the episode, guys. Until the next episode, bye.
Bye. Bye.
How do you feel?
Oh, this was so fun actually.
Which verb comes here? Which verb? Like you forget English.
Nikakumbuka niko like what will I say here, nikasema unajua nini kona edit actually hearing it back you might find there are more fumbles, but you know what. But then now that you say that, I think there's a point I should have added is because so because we've been doing all these things for years. The thing is also mosquitoes gain a resistance. I mean, the parasite itself gains a resistance to the insecticides that are being used. That's also one of the challenges is that for all the things we've been doing treating nets, now the parasite has gained a resistance to it. So it's not working as well anymore. That's why we can't have it just one tool. So now vaccine pia sasa ndio inakuja iko like sawa, let's try. Resistance also making new insecticides that counter the one that's resistant takes time. But hey, the vaccine took 60 years, 60 whole years. The COVID vaccine isn't a good example because a year to make the vaccine, but that's because it was very urgent. But it takes so much time to get a vaccine in circulation. Because most of the vaccines we have now, they were made in the 40s, 1940s, 1930s. Ndo sasa zikatufikia. Yeah, they're really old. They're really, really old. And even Africa were like the last people to get. They update, but like the original one sasa ndo ianze ndo iupdateiwe. Version 1 was in the 1930s.